Assalamu alaikum. Good morning. My name is Dr. Syed Nadeem and I'm working as an anesthesiologist at Al Batin Central Hospital, Kingdom of Saudi Arabia. Today my topic is updates in American Heart Association, BLS, ACLS, PALS 2020. Update number 1. A sixth link recovery has been added in 2020 adult and pediatric out of hospital cardiac arrest and in hospital cardiac arrest chains of survival. As we all know, in 2015 there were 5 links in all 4 chains of survival, but in 2020 an additional a sixth link recovery has been added in all 4 chains of survival. The question is why this sixth link recovery has been added in all these 4 chains of survival. The answer: the process of recovering from cardiac arrest extends long after the initial hospitalization. Support is needed during recovery to ensure optimal physical, cognitive, and emotional well-being and return to social role functioning. This process should be initiated during the initial hospitalization and continue as long. Update number 2. Early initiation of CPR by lay rescuers. Lay persons should initiate CPR for presumed cardiac arrest because the risk of harm to the patient is low if the patient is not in cardiac arrest. The question is why? Then answer: new evidence shows that the risk of harm to a victim who receives chest compressions when not in cardiac arrest is low. Lay rescuers are not able to determine with accuracy whether a victim has a pulse, and the risk of withholding CPR from a pulseless victim exceeds the harm from unneeded chest compressions. Update number 3. Adult rescue breathing when no normal breathing and pulse felt. In 2015, the recommendation for rescue breathing was give one rescue breath every 5 to 6 seconds, that is 10 to 12 breaths per minute. But now in 2020, the recommendation has been updated for rescue breaths. Give one rescue breath every 6 seconds, that is 10 breaths per minute. Update number 4. Update in 2020 Pediatric BLS, PBLS. Rescue breathing when there is a pulse but absent or inadequate respiratory effort. In Pediatric BLS algorithm 2015, the recommendation for rescue breath was Q1 rescue breath every 3 to 5 seconds, that is 12 to 20 breaths per minute. But in 2020 Pediatric BLS algorithm 2020, the recommendation is give one rescue breath every 2 to 3 seconds, that is 20 to 30 breaths per minute. Update number 5. Update in 2020 PALS Pediatric Advance Life Support breathes when advanced airway, for example endotracheal tube or supraglottic device just like laryngeal mask airway is in place. In 2015, the recommendation was give one breath every 6 seconds, that is 10 breaths per minute with continuous chest compressions when advanced airway, for example endotracheal tube or supraglottic device just like LMA is in place. In 2020, the recommendation has been updated and now give one breath every 2 to 3 seconds, that is 20 to 30 breaths per minute with continuous chest compressions when advanced airway is in place. The question is why? Answer: new data show that higher ventilation rates, at least 30 per minute in infants and at least 25 per minute in children, are associated with improved rates of ROSC and survival in pediatric cardiac arrest. Although there are no data about the ideal ventilation rate during CPR without an advanced airway or for children in respiratory arrest with or without an advanced airway. For simplicity of training, the respiratory arrest recommendation was standardized for both situations. Update number 6. Emphasis on early administration of epinephrine. With respect to timing, for cardiac arrest with a non-shockable rhythm, that is asystole or pulseless electrical activity, it is reasonable to administer epinephrine as soon as feasible. The question is why? Answer: the suggestion to administer epinephrine early with a non-shockable rhythm, that is asystole or pulseless electrical activity, was strengthened to a recommendation on the basis of a systemic review and meta-analysis showing that epinephrine increased ROSC and survival. Patients who received epinephrine within 5 minutes of CPR initiation compared with those who received epinephrine more than 5 minutes after CPR initiation were more likely to survive to discharge. Update number 7. Updates in 2020 Adult Cardiac Arrest Algorithm. Addition of lidocaine as an antiarrhythmic agent in addition to amiodarone for shock refractory ventricular fibrillation or pulseless ventricular tachycardia. In 2015, there was recommendation only for amiodarone. The dose intravenous or intraosseous, first dose 300 milligram bolus, second dose 150 milligram bolus. But in 2020, not only there is recommendation for amiodarone, but there is also recommendation for lidocaine. So we can use either amiodarone or lidocaine. If amiodarone is available, okay. If not available, then we can also use lidocaine. The dose for amiodarone remains the same, intravenous or intraosseous route. First dose 300 milligram bolus, second dose 150 milligram bolus. For lidocaine, intravenous or intraosseous, first dose 1 to 1.5 milligram per kilogram, second dose 0.5 to 0.75 milligram per kilogram every 5 to 10 minutes, maximum 3 doses or maximum dose 3 milligram per kilogram of lidocaine. Update number 8. Update in atropine and dopamine dose in adult bradycardia with the PALS algorithm. In 2015 adult bradycardia algorithm, atropine, the recommendation for atropine was first dose 0.5 milligram, repeat every 3 to 5 minutes, maximum 3 milligram. But in 2020 adult bradycardia algorithm, the first dose has been changed from 0.5 milligram to 1 milligram. So now the first dose is 1 milligram. Frequency will remain same, repeat every 3 to 5 minutes, and the maximum dose will remain same, 3 milligram. Dopamine IV infusion in 2015 adult bradycardia algorithm, the recommendation was usual infusion rate is 2 to 20 microgram per kilogram per minute. In 2020, usual infusion rate is from 2 to 5. So it has been changed from 5 to 20 microgram per kilogram per minute. Instead of 2 to 20 microgram per kilogram per minute, now it has been updated to 5 to 20 microgram per kilogram per minute. Update number 9. Update in the time for performing perimortem caesarean delivery, PMCD. As we all know that there is a separate cardiac arrest algorithm in pregnancy. So in 2015, the recommendation was if there is no ROSC by 4 minutes of resuscitative efforts, consider performing immediate emergency caesarean section. But in 2020, if no ROSC in 5 minutes, consider immediate perimortem caesarean delivery. So the time has been changed from 4 minutes to 5 minutes. Update number 10. Updates in the adult immediate post cardiac arrest care algorithm after ROSC, return of spontaneous circulation. Post cardiac arrest care algorithm 2015, the recommendation was maintain oxygen saturation equal to or greater than 94%. But in 2020, the recommendation is maintain oxygen saturation, that is SpO2, between 92 to 98%. So from 94%, it has been changed to 90 to 98%. If patient remains comatose after ROSC, initiate targeted temperature management. So in 2015, there was only recommendation for targeted temperature management. But in 2020, not only there is recommendation for targeted temperature management, but there is also recommendation for obtained brain CTs, EEG monitoring, and other critical care management. Update number 11. A new diagram, neuroprognostication diagram, has been added in ACLS 2020 to guide and inform neuroprognostication. Hypoxic ischemic brain injury is a common sequel to cardiac arrest in patients who gain ROSC after cardiac arrest but remain comatose after ROSC. A new diagram, neuroprognostication diagram, has been added in ACLS 2020 to guide and inform neuroprognostication. Clinical management and different diagnostic tests for multimodal prognostication. Number 1, clinical management. Targeted temperature management should be initiated promptly. A constant temperature range between 32 degrees centigrade and 36 degrees centigrade should be maintained for a minimum of 24 hours. After 24 hours, start rewarming of the patient. After 48 hours, limit sedation and analgesia as possible, and then proceed for controlled normothermia. Number 2, imaging. Head CT scan should be done within first 24 hours. MRI should be done after 48 hours. Number 3, electrophysiology. Somatosensory evoked potential should be done after 24 hours. EEG for bus suppression after 72 hours. EEG for persistent status epilepticus after 72 hours. Number 4, clinical examination. Status myoclonus, record EEG after 24 hours. After 72 hours, assess pupillary light reflex, quantitative pupillometry, corneal reflex. Number 5, serum biomarkers. After 24 hours, measure serum neuron-specific enolase. To be reliable, neuroprognostication should be performed no sooner than 72 hours after return to normothermia, and prognostic decision should be based on multiple modes of patient assessment. If patient remains comatose 72 hours after ROSC and normothermia and no residual effects of sedation and analgesia, the following features indicate poor prognosis: the absence of pupillary and corneal reflexes, bilaterally absent somatosensory evoked potential wave, status myoclonus, high neuron specific enolase values, unreactive EEG with bus suppression or status epilepticus, diffuse anoxic injury on brain CT and or MRI. Update number 12. Two new opioid-associated emergency algorithms have been added in 2020 ACLS for lay rescuers and trained rescuers. Update number 13. Physiologic monitoring of CPR quality. It may be reasonable to use physiologic parameters such as arterial blood pressure or end-tidal carbon dioxide when feasible to monitor and optimize CPR quality. The question is why? Answer: although the use of physiologic monitoring such as arterial blood pressure and end-tidal carbon dioxide to monitor CPR quality is an established concept, new data supports its inclusion in the guidelines. Data show higher likelihood of ROSC when CPR quality is monitored using either end-tidal carbon dioxide or diastolic blood pressure. The monitoring depends on the presence of an endotracheal tube or arterial line respectively, targeting compressions to an end-tidal carbon dioxide value of at least 10 mm Hg and ideally 20 mm Hg or greater may be useful as a marker of CPR quality. Update number 14. Cuffed endotracheal tube is preferable to uncuffed endotracheal tube in infants and children. 2020 updated, it is reasonable to choose cuffed endotracheal tubes over uncuffed endotracheal tubes for intubating infants and children. When a cuffed endotracheal tube is used, attention should be paid to endotracheal tube size, position, and cuff inflation pressure, usually lesser than 20 to 25 centimeter of water. 2010 old, both cuffed and uncuffed endotracheal tubes are acceptable for intubating infants and children. In certain circumstances, example poor lung compliance, high airway resistance, or a large glottic air leak, a cuffed endotracheal tube may be preferable to an uncuffed tube, provided that attention is paid to ensuring appropriate endotracheal tube size, position, and cuff inflation pressure. The question is why answer several studies and systemic reviews support the safety of cuffed endotracheal tubes and demonstrate decreased need for tube change and reintubation. Cuffed tubes may decrease the risk of aspiration. Subglottic stenosis is rare when cuffed endotracheal tubes are used in children and careful technique is followed. Update number 15. Intravenous access preferred over intraosseous for administration of medication during cardiac arrest. 2020 new, it is reasonable for providers to first attempt establishing intravenous access for drug administration in cardiac arrest. 2020 updated, intraosseous access may be considered if attempts at intravenous access are unsuccessful or not feasible. Question is why answer in 5 retrospective studies, the IV route was associated with better clinical outcomes as compared to intraosseous route for administration of medication during cardiac arrest. Update number 16. Umbilical vein recommended route for newborn babies for intravenous access. 2020 new, for babies requiring vascular access at the time of delivery, the umbilical vein is the recommended route. If intravenous access is not feasible, it may be reasonable to use the intraosseous route. The question again why answer newborns who have failed to respond to positive pressure ventilation and chest compressions require vascular access to infuse epinephrine and or volume expanders. Umbilical venous catheterization is the preferred technique in the delivery room. Intraosseous access is an alternative if umbilical venous access is not feasible or care is being provided outside of the delivery room. Several case reports have described local complications associated with intraosseous needle placement. Update number 17. Double sequential defibrillation not supported. 2020 new, the usefulness of double sequential defibrillation for refractory shockable rhythm has not been established. Question again why answer double sequential defibrillation is the practice of applying near simultaneous shocks using two defibrillators. No evidence found to support double sequential defibrillation and therefore its routine use is not recommended. It is recommended that changing the direction of defibrillation current by repositioning the pads may be as effective as double sequential defibrillation while avoiding the risks of harm from increased energy and damage to defibrillators. Update number 18. Cricoid pressure during intubation not recommended in pediatric patients. 2020 updated, routine use of cricoid pressure is not recommended during endotracheal intubation of pediatric patients. 2010 old, there is insufficient evidence to recommend routine application of cricoid pressure to prevent aspiration during endotracheal intubation in children. Question is again why? Answer, new studies have shown that routine use of cricoid pressure reduces intubation success rates and does not reduce the rate of regurgitation. There is reaffirmation of previous recommendations to discontinue cricoid pressure if it interferes with ventilation or the speed or ease of intubation. Thank you for watching this video.